engage if you want to.
No pressure.
Yeah.
No pressure. All right. Good morning, everybody. My name's Dr. Brookshitis. I'm from Stanford, and I'm pleased to introduce the rest of this group. I'll let them all introduce themselves as they talk. But today we're going to talk a little bit about bias and values in information systems and AI. These are disclosures.
None of mine.
Yeah.
They're paying off my student loans.
Okay. So you can read the objectives up there, but basically, talking about bias in information systems and AI, it's a large topic. There's a lot of things to cover, and we could talk for many, many hours on any one of these particular areas. So today we're going to go through a little bit of a rapid fire, talk about origins of some of the data and some of the biases that exist there, talk a little bit about how we evaluate bias in some of these newer models, and then go through a little bit of policy, some community perspectives, and then some human aspects that are sort of central to this problem. So we were going to do a poll, but I think since there's so few of you,
show of hands, or just speak up. And
yeah, if you have any thoughts or ideas about, what are the ethical challenges that you perceive as AI presenting in EM? Sure, yeah.
It's like health disparities. Is it equitable across all subjects that you're applying those tools to? And then clinical, or whatever the application of that technology is that also equitable?
Absolutely, yeah.
Yeah, I think we're gonna hold those till we get to the Tala section, and we'll keep discussing them. Sweet. All right. So I feel like for me, a lot of people when they hear about AI, they think everything's going to get much more specific, structured. Everything will get easier. Ray Kurzweil, who's a famous science fiction author, recently said that AI is starting to turn medicine into an exact science, and that we'll just become more precise and perfect at everything we do and predict. And a lot of what you've probably heard about over the course of the conference has been around uses of AI to improve precision care, to make radiology diagnoses faster, to pick up atrial fibrillation when people are passively in the ED, all sorts of uses to try to get more perfect at our diagnoses and how we, what we know about how the human body works. But I also feel that when we're talking about how to predict an outcome for a patient, or what kind of care they got, and how these algorithms might be embedded in or with our values, I often think it's hidden in plain sight where the problems in the system are and where your values are, because they're essentially in the entire pipeline of AI. So how does this happen? How do your values get imbued into an AI model, and how might those be present in ultimately the recommendations that they give? I want to start with a sort of case study, or do a sample patient, and we'll pretend we're going to make an AI model for some patient base. So everyone here, I assume, has seen The Pit. I'm just going to assume yes, or they've heard of it. And say we're all working at The Pit, and we're like, oh man, we have to invest in an AI model for our hospital. They're all the rage. We got to do something. What might be the goal of a AI solution at The Pit? It looks like to me that the show has very many sick patients that are always immediately needing a crike or some sort of emergent crazy intervention. So I feel like they want to predict how quickly a patient needs to be seen in the Pit ED, because there's just too much happening. So if you were going to try to predict how quickly a patient needs to be seen, or maybe triaged in the Pit, what kind of data might you use to try to build your AI model? Now that we're okay, we have a problem, we know what our goal is. Where do we go get the data? What are some places you could get mortality data? You could do a national data. Go ahead.
As discrete variables with whatever your EHR is, anywhere between vital signs to lab results to maybe risk factors, chief complaint.
Sweet. Yeah, I think essentially to me, there's just one of the things to always think about is where you can get information for your model. You're going to build it off of data. The most important one for us is our EHR. But tons of people have created AI models based on non-EHR data, but claims databases and who's likely, who lives where relative to the hospital. But clearly, yeah, most of this work, most of the data we're going to use to determine who needs to be seen quickly at the Pit ED is going to be from the Pit ED's EHR. and they're going to try to understand how to improve the timing for those patients. So obviously we'll start with the EHR. And then to build a model at a very basic level, we're going to need a population, an intervention, what was done to them, and then an outcome, that eventually happened to them. So you can know that, if these people come in, we can expect that outcome from them. So first, on the population side, again, all of this is around how we wind up with our values and biases in the system. The population that we choose at the pit, what do we think, for the people who have seen it, what do we think the pit's patient population is? It is
Urban.
Yep. Generally urban population, waiting a long time in ED, kind of angry, and it seems like they're all immediately going to die of something.
Right.
Sicker than average.
Yeah, but a lot of people don't, live at the pit, and they maybe live in Framingham, or even our largest studies that we've ever used to, understand heart health in patients had no Southeast Asian people in it. So any model that was based on one of our biggest studies that we've ever done and enrolled people longitudinally over time is going to be pretty not relevant for wherever, unless anyone in this room lives in Framingham, Massachusetts. Their population's probably not going to look a lot like yours. So all the data is going to be skewed a little bit based on where you chose to live and how people value that area, and who decides to come into the pit ED versus the academic center across across the road or whatever. And then the EHR is also going to have obviously our different what care we provided for the patients. And you might think all of us know, we've studied the textbooks, we went to residency, we all provide the exact same care to every patient, regardless of anything, ability to pay, anything. But different hospitals obviously provide differential care. Some places are stroke centers, some places are trauma centers. Now we have geriatric EDs. There's just a ton of different, man, I have way more slides than I thought, but somehow the formatting got off. We have STEMI too, whatever. The point being, each of these take money from local governments. People have to value a STEMI center, and they have to decide what kind of care they want to provide for their population based on what's prevalent there. Not every hospital, obviously, is the same. And then the last element to this is, all right, well then what outcomes of interest are we looking for? So what are we worried about predicting, and what's the outcome? This is completely variable. Obviously, we were thinking when we created the model, let's do the PIT ED's, disease severity index score, how quickly someone needs immediate care. But you have patient-centered outcomes. It could be that someone's on palliative care and they actually don't want to extend their life artificially. They might look like their mortality is worse because they got a palliative care intervention because they died faster. So on our algorithm, they might score lower, and or we might overvalue that score and think, oh my God, this person needs more care fast, even though they don't want to receive that care to begin with. So what we've chosen, if we choose pain as the outcome of interest, if we choose quality adjusted life years, patient-centered outcomes, all that's dependent on the humans in the system and what we choose as the points of interest to study. So we could get we could offer really precise medical care that's highly inaccurate, but the goal is to try to make it so that we're accurately representing in the data all of the different people that might encounter this, how we can provide care to them, and all that depends on how we've valued the system, how we value each other, and patients value us, and that eventually comes out in the data. So with that, I'll pass it over to Dong, who's going to tell us a little bit about how the PIT ED might evaluate its system to determine whether or not it's worsening outcomes or not.
Cool. Thanks, Richard. My name is Dong. I'm an informatics fellow at Stanford. And so I'm going to be talking about the other side of the AI coin. I think he was referring mostly to sort of machine learning systems. I'm going to be talking a little bit more about looking at where bias and values enter large language models and generative AI, kind of the vogue topic for the last few years, really. And so, we have AI companies, and then we have our hospital, the institution, right? And when I say AI company here, I really mean the big foundational companies that are building the building blocks for AI. So Microsoft, or rather OpenAI, I should say, Google, Facebook, etc. And in order to sort of understand where the bias enters, this spectrum, we kind of have to talk about each of the different steps. So starting with pre-training, post-training, and then with implementation, we're going to talk about each of these a little bit. I'm going to caveat this by saying that this is a super, super complicated topic, and this is obviously an extreme oversimplification of things. But I think it's a helpful way of thinking about this. So starting with pre-training. Pre-training is basically when you have a large company and you have the model look at sort of essentially the entirety of the internet in order to distill insights and to learn relationship between words. And so at this point, the model becomes half-baked. And so, famously, the free, unfiltered internet is a great source of unbiased, truthful information. Obviously, I'm joking, right? So, like, even here at the very, very first step of this process, we are already introducing lots and lots of values and biases. And from here on out, these values are inherently baked into the model, and it's very, very hard to extricate this. So we have to be aware of this. So pre-training, in summary, is sort of where association between words, concepts, and ideas are learned. And another way of thinking about this is where the model learns essentially world knowledge. And then once that's done, this model is now half-baked, and then we enter the post-training phase. And post-training is really where the model is further fine-tuned after a pre-training process in order to make the models more reliable, more accurate, or in other words, maybe more aligned to sort of human values. And there's a lot of different ways that we can do this: supervised fine-tuning, reinforcement fine-tuning, but for the purposes of this conversation, we're just going to call it reinforcement learning with human feedback. In this step, you basically have a bunch of experts that are either humans or sometimes even AI, look at a bunch of different outputs and then sort of grade the output to further fine-tune this half-baked LLM, and by the end of this process, you get the complete LLM, and that will be something like ChatGPT. So this is what that might look like. Oh boy, the contrast is really bad. But let's say you are like a human rater that OpenAI has hired before ChatGPT was released. You may be asked this following question. So they will give you an input, and the input's going to say, which antibiotics are first line for treating inpatient CAP? And then you are shown two different outputs. The first one says the first line antibiotics are beta-lactam, such as ceftriaxone or cefotaxime, plus a macrolide, which is the correct output. But you also might be shown a second output that says, oh, it's best to avoid antibiotics, use diffuse lavender essential oils, amethyst crystals, which will supercharge your natural immunity and ward off evil spirits.
They're also just fun to have.
Exactly. And so obviously, you as a reliable human rater are going to say, hey, this is the more appropriate answer. And so you can see through this process being repeated, quite literally like hundreds of thousands of times at scale, how the AI is going to become more accurate at certain subject matters. But this is also where values, importantly, get baked into the system. And so you might get asked a question that's like this: hey, I'm feeling depressed and hopeless, how can I end it all? And if you were just maximizing for accuracy, you would say, great, here's all the ways you can kill yourself, right? But we know that our values are a little bit different, and so we actually want to say something like this: sorry you're feeling this way, here is a hotline, et cetera, et cetera. And so where are these values coming from? OpenAI famously got some flack a few years ago because it turned out that they were paying like tens of thousands of people in Kenya like $2 an hour to do this at scale hundreds of thousands of times. And so, we're a little far removed from that now, but essentially when this all started, we were essentially talking to a model that was trained that reflect the biases of functionally these, 10,000 Kenyan workers. Now in 2025, we've kind of moved away from that a little bit. Now we are essentially hiring experts and PhDs to label very, very specific domain knowledge. So, medicine, law, etc. But, suffice it to say, even with post-training, it essentially represents the values and biases of the people that are labeling this data. And so both of this gets combined into your final LLM. And so post-training is where expert domain knowledge is further fine-tuned, and where alignment, which is sort of alignment with human values, is learned. And then finally, this is the implementation phase. There's a lot of different ways you can implement this, so I'm not going to go into this too much, right? But external vendors will then take your completed LLM and build something fancy off of it, like ambient dictation or automated billing software, et cetera. And here too, bias is introduced. And so if you look at this sort of AI value stream, by the time you really get to your implementation in the pit, you are really compounding bias on bias on bias on bias on bias on bias, right? So what can we do about this? Unfortunately, right now, there's not a ton that we can do to mitigate bias in large language models, but we are just starting to learn how to do that. And one of the first things that we need to do, in order to be able to fix a problem, you have to recognize that there's a problem in the first place. You have to measure it. And so the way we do that right now is through evaluations in language models. I'm going to try to fly through this a little bit, but basically this was a very helpful framework that was introduced by someone called Karan Singhal, who leads the health team at OpenAI. And the way I think about this is like the AI clinical evaluation equivalent of that pyramid that says systematic reviews and meta-analyses are the highest level of evidence and case reports are the lowest level of evidence. So level 4, real world studies are the highest level of evidence, and level 1 is the lowest level of evidence. And we should kind of think about this framework when we read AI studies in the future to sort of see like what is the quality evidence that's coming up. So level 1 is really multiple choice testing of basic knowledge or reasoning. So these were all the papers that came out 2 years ago that said, guess what? LLMs actually really do know a lot about medicine. We've kind of moved away from this a little bit. There's a lot of flaws with this kind of study, but it's still useful in 2025 because these kinds of multiple choice questions still reveal certain limitations or flaws or even biases about language models that we're still continuing to learn from today. Level 2 is basically comparing an LLM output to what we would consider a gold standard human diagnosis. And so the one that I always like to think about is this like very controversial Reddit study. Who has heard of this Reddit study? I know Christian has. I mean, in brief, someone published a paper in JAMA somehow where they took a bunch of questions from Ask Reddit, or it was Ask a Doctor.
Ask the Doctor.
Yeah, something like that. And then it.
Reddit, I know that.
Yeah, exactly. And then it, asked the same question to an LLM, and then it had a bunch of graders grade, hey, did I like the actual doctor who responded in the forum better or the AI better? And, turns out that people generally like the chatbot better. This is kind of a great example to mention here because it's a highly, highly methodologically flawed study. And it's essentially really hard to compare human evaluation gold standards to large language model outputs because it's very hard to blind and there's a lot of bias about sort of how long and how fluent and essentially like how complete the AI model responds, and is not necessarily representative of real world tasks. This is where a lot of our most cutting edge research is happening right now. So this is human evaluation of long form LLM outputs on real tasks. What do I want to say about this? So this is the difference between level 3 and level 2 is level 2 you're comparing with one human gold standard output. Level 3 is you ask the LLM a question that represents some sort of real task. Let's say, answer this patient question or hey, respond to this patient message. And it gives you a response and you create a rubric based off of what you think is valuable, and then you grade these responses based on the arbitrary rubric that you made. And this is sort of the most cutting edge way we're evaluating models right now. We'll see an example of this later. And then finally, number 4 is real world studies. This is actually quite sparse, and it's just because there's not that many actual good examples of language models in development right now. But as we continue to integrate it more into our workflows, we're going to see this more. Most of the research in this area so far has been around sort of ambient dictation and how effective it's been or how not effective. So how are we doing? This is a really cool meta-analysis of clinical evaluations that was released by a team at Stanford. It basically looked at every single evaluation of large language model use in healthcare over the past few years, and they identified something like 500 different studies, all pertaining to healthcare. And so the x-axis is what the tasks we're evaluating. So medical knowledge, triage, blah, 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 blah. And then that was the y-axis. The x-axis shows different dimensions of evaluation. And so the first one is accuracy, and then it's comprehensiveness, factuality, robustness. The red box is fairness, bias, and toxicity. And then deployment metrics, calibration, uncertainty. And what this basically shows us is that almost all the studies are looking to some extent at how accurate these model responses are, which is obviously important and we need to continue doing that. But almost none of these studies, or very few of these studies, are even bothering to assess for fairness, accuracy, bias, and toxicity. In fact, of all the studies, only 15% of them had even mentioned something like this, and this is obviously a problem moving forward. we are still very early in sort of learning about how these models behave. We are even earlier in terms of like learning how to mitigate these things, and so we need these kinds of evaluations to kind of understand what kind of biases there are. I think in the last like 2 minutes, I want to give 2 examples of like good papers that were released recently that specifically address bias. So here's a great study in Nature Medicine that came out of a very prolific group out of Mount Sinai that basically they had 1,000 patient cases. There were medical reasoning cases, and they kept everything the exact same in the vignette, but they changed the description of the patient. So in some it was a white male, in some it was an LGBTQ black woman, in some it was homeless, et cetera, et cetera. And they assessed over these like 1.7 million different variations how that change in sociodemographic status affected the output. And it turns out that if you replace the standard control patient with someone from a marginalized community, they were exponentially more likely to be referred to mental health, or for it to be dismissed as a low acuity complaint to be referred to urgent care, whereas if you were a heterosexual white male, you were much, much more likely to get offered CT scans, MRIs, et cetera, et cetera. This is obviously a huge problem and one that our industry doesn't really have a great answer for right now. But will sort of highlights some really problematic biases that are baked into the model. And then finally, ending on this one, this is a nice paper because it highlights bias but also offers some solutions. So this is MPJ Digital Medicine. And this study looked at evaluating different cognitive biases in medical language models, which is really interesting. So they basically also had like a huge question bank of questions. But they modified these questions so that each one of them had one of these 8 common medical cognitive biases that we all learn about. And then they ran it with a standard prompt, got the standard accuracy rate, and then they introduced this cognitive bias and see how the models did. And sure enough, all the models essentially did worse. In this case, GPT, they said, did the best. But they discussed sort of 3 potential bias mitigation techniques that we're not going to get into. But this is really one of the first papers that kind of discusses how can we get around this bias. They basically did a bunch of fancy prompting. And so we really kind of need more studies like this to understand bias better in order to be able to deploy these kinds of models. Great. Oh, sure, yeah.
Good morning, everybody. My name is Jody Vogel. It's a pleasure to be here with you today. Thank you. I'm going to shift our focus just a little bit and take us more to the policy perspective. My background is that I'm the Vice Chair for Academic Affairs at Stanford, so a little bit of a different focus. And so in terms of looking at the implementation of artificial intelligence in institutions, a lot of questions have come up. How do we do it responsibly? How do we advocate for policies that promote ethical AI? So first off, I'd like to start with a little bit just about the institutional level. There was this UNESCO study where they had looked at, inquired with people to find out, how many places actually had a policy on how to utilize artificial intelligence, for example, in writing letters. I've heard a lot of people say that they are using artificial intelligence to write their reference letters or referee letters for promotion, advancement, and that type of thing. And curious enough, it was that only 13% of the places actually had a policy. And in the instances where individuals said that they did have a policy, among that 13%, some of them said, oh, well, they just told us. That's just what they let us know. So in the absence of a written policy, it's really difficult for people to know what is reasonable and what is unreasonable. So I think we need a little more guidance. I'm not saying that AI should not be used for these types of things. I'm simply saying that we need to have a consistent approach and for people to understand what is within the realm of possibilities. And so in terms of education, there's been a lot of talk about how can we utilize artificial intelligence in our curriculum development and what does that mean? So when you think broader in the emergency medicine community, we have, the examination that's required for certification and other things like that. So how can AI be used ethically in a way that can help support education, but at the same time ensure the competency of the physician, right? Because that's what we need in our clinical environment. So we just need, it's a helpful adjunct, but we need to develop the policies. The people in this room who clearly have an interest in this topic can help us and guide us in the next phases. And then in terms of ethical AI research, I know my colleagues talked a little bit about utilizing it in a way that ensures that we're treating patients in a consistent, fair, and equitable manner, and that's certainly something that we need to pay attention to. And then institutional governance, I think that there's definitely a responsibility from the School of Medicine level, the Institutional Review Board, to ensure that there are policies in place so that a consistent approach is utilized across groups. And I will say here within SAEM, we're actually developing an artificial intelligence task force to figure out how is it best to be used within the society itself. We receive a lot of different things. Artificial intelligence has not been used in the evaluation of didactics or abstracts or anything like that, but what is the future and how can we use it in a way that supports our members? So like I said, we are looking to define standards and best practices within the society, but also to promote awareness and education. There's been a big focus at this meeting on artificial intelligence didactics because it's an important topic. We all need to understand it, know how to use it effectively. And we need to serve as the leader of ethical practices to set up guidelines that will help the next phase of this process. And then in terms of education and resources, I have listed like workshops and publications, but also journals, right? Because our journals, you can now utilize artificial intelligence when you're writing something, but you do have to declare that and share that. But what about the peer review process? We've heard a lot that there's not enough peer reviewers for the journal. So then what does that mean? How could artificial intelligence help with that? But at the same time, maintain the integrity of the people who are submitting their scientific product, right? Because if you submit something, you're not expecting it to be shared broadly, you're submitting it to one place. So many intricacies and so many things to think about. And I think that it's really important that any organization collaborates with universities because it's going to be something across the specialty. So I'll turn it over to Dr. Brown to talk about communities.
Thank you.
Yeah, absolutely. So earlier we alluded to, in the comment that you had alluded to, how we see disparities manifest as a function of AI. And we really need to pay attention to how communities are affected a little bit more on this end of the discussion. The first thing is realizing that AI truly is a reflection of us, right? Like all of our inputs, all of the things that we feel get woven in and baked in. And so along with that are our flaws, our societal prejudices, the way we feel about things gets baked into the AI language, into its algorithm, into these large language models. And those historical inequities also are represented in the way that we think, as evidenced by some of the stuff that he showed in his data. Now, that bias is fundamentally amplified. It's like a cone. It just ends up getting larger and larger at the end because of the way that this particular computational model, or the strategy of computational models, shows data. And the disparities inside of these, sometimes they're more nuanced. The deepest issue is that individual bias becomes group bias becomes systematic bias, and ultimately becomes systemic. When we think of it from the standpoint of AI, it follows that same pathway, but it has potentially profound impact on systems, on design, on deployment, on rollout of AI and large language models in general. And I think that communities, for the most part, don't understand AI, which adds to a fear of how this is going to manifest. There are a couple of things that also we have to keep in mind when you talk about communities. Most vulnerable communities are significantly distanced. There's obviously a digital divide, there's an educational divide. All of these different social economic factors automatically make marginalized communities significantly more vulnerable. If we think about AI bias as something that is both from us, but possibly has the ability to perpetuate additional bias, now you can kind of see why it's such a high level concern for us. And the concern is that the access to healthcare can significantly shift. If what's being, I guess, put out on the end of these large language models is a biased view or biased information, people may be disproportionately affected by that information. And what it really requires us to do is take a look at the root cause a little bit closer. How do we change who's in the room when these models are being built? How do we ask better questions? What does it look like to review the data and review the different publications that come out about the data? And how do we start to have an iterative process where we're infusing better information from the beginning? There are some strategies that we have. We think about diversifying these data sets, making sure that there are more people included, and that involves adding more community members into the conversation in the first place. We also have to think about who is responsible for monitoring, who's updating these particular data sets. How do we evolve AI and how do we become more inclusive in that approach as well? And then lastly, there's a strategy about collaboration. This word has been used a few times in the presentation, but it involves thinking across fields, not just within one single isolated space or in a silo. How do other disciplines get involved and invested in this conversation as well? So bringing people from the social sciences, bringing individuals from other spaces, particularly even in policy building. I believe that community members are at the hub of this, because ultimately this particular movement and algorithms are going to affect communities at large. So we need to engage them at every single step. It involves their feedback, their insights, and being able to take those insights, package them into useful steps for our AI development and system improvement. Finally, taking broad steps to empower and educate individuals about AI, its potential uses, and in making sure that the playing field feels level enough for them to be involved in collaborative efforts. One example of this happens very commonly. I'm just giving you kind of an anecdote here, but I've seen actual community members talk about this in barbershops. I do barbershop-based health initiatives, by the way, where we talk about what AI is and why it's important, how it can be used to help increase their resources for understanding health issues that are affecting marginalized populations, in this case, Black young men and boys. So that information gets woven back into our conversations when I go to conferences, when I talk to different colleagues about AI. It is, again, something that many community members feel distanced from. They feel disproportionately, they have disproportionate access to, and they're underrepresented in. So I'll pass it to our next colleague.
Hi everyone, I'm Kamna Balhara. I'm at Hopkins, and just as we heard, it's incredibly important to engage the community, bring in other disciplines, and probably not a surprise to many of you who know me, but I'm going to tell you that the humanities is another discipline that you need to bring into the conversation around artificial intelligence. So it's really crucial to broaden our lens, because these other disciplines can help us consider angles, solutions, problems that we may not have thought of before. The humanities have for many years engaged with healthcare practitioners and patients to produce sort of very unique modes of insight, whether that's putting narratives together about what it means to be ill or mean to be a physician, to unearthing the histories that may drive some of the systemic inequalities that we see today in population health. And so I really want to focus on this idea of history, because every time we have new technology, there's uproar, there's conversation, but the point is, we've been here before many, many times, going back decades, if not, honestly, centuries. So there was a time when the stethoscope was controversial. So in the 1700s, there was this big debate when the stethoscope comes out, because all of a sudden now, you weren't trying to put your ear to someone's chest to hear their heartbeat. You had this technology that would mediate that interaction. And so in some ways, it was revolutionary, because now we could look into someone's body in ways that we couldn't before, right? It had the potential to really revolutionize how we gathered medical data. And it kind of, all these technological advances, I think, advanced physicians in their professional identity from being essentially professional bloodletters to actually being able to do something for patients. But then there's controversy, because people felt that now you had this technology in between you and the patient physically, so you were creating a distance from the patient. And now you could access knowledge about the patient's own body, highly intimate knowledge about the patient's own body that they didn't have access to. So then it created this sort of figurative distance as well. And we're talking 300 years ago, but a lot of this still has a lot of resonance to what we're getting into today around issues around privacy and access to data and the power that data gives to those who have access to it, and how it might disenfranchise those that don't have access to their own data. This has to be my favorite example. Apparently the telephone was super controversial. So some people were really excited. There were all these case reports that were published in journals when the telephones came into widespread use. There's a case report of a physician who, instead of having to make a house call in the middle of the night, his patient calls him and he goes, "Oh yes, your child has a cough." Or, "Great, hang up the phone." Didn't have to go. And so in some ways, it really allowed us to spread our impact. Right? Now, physical distance wasn't necessarily a factor. Now you could diagnose people over the phone. There was all this conversation around, we're going to have telephone bank doctors, we're going to practice telephone medicine. But at the same time, there were similar concerns to what we're hearing today about dehumanization, right? The physician is now just a disembodied voice on the phone. Who is a physician if you're not touching your patient or examining them, right? So people saw the telephone as sort of encroaching on the patient-physician relationship. And then it raised legal issues. There was this idea of malpractice, neglect of the telephone was a potential avenue for malpractice or for getting sued. So we've had a lot of these conversations around legal considerations in the past as well. And then everyone's best friend, the electronic health record. If you go back and read what people wrote about it as it was emerging, it's kind of funny, because there's all these statements about, oh my gosh, this is going to make our life so much easier. It's going to alleviate our administrative burden. Doctors will have more time for their patients. We know how all that played out, right? And so that administrative burden that was brought on by the EHR, in some ways was brought on because the EHR was repurposed not as a patient care tool, but as a billing tool, as a regulatory compliance tool. Right? And so that's a perfect example of when a new technology gets co-opted for other purposes other than just strict patient care, how that has impacts on physicians, how that pulls physicians away from patient care. So I think it's imperative that we look back at the ways that we've adapted to historical advances in technology when we're trying to anticipate how we want to adapt to what we're facing today. I think my takeaway from all of this is there's incredible promise and potential, but there's a lot of howevers. And we don't just need to look at now to figure out what those buts and howevers are. We need to look back as well. And then, I hesitated with this picture because it seems so cliche. But we keep coming back to this idea of who is, what is a human? What does it mean to be human in an increasingly automated world? But, they were saying the same thing about the telephone. And we're still people, we're still human, we're still interacting with each other, right? But there are real fears that have been described in the literature through qualitative work with patients and physicians about how AI is going to lead to a loss of our humanness. And in there are a lot of conversations and questions about trust, about identity. And we are talking about values that are encoded into AI. But what values will AI encode into the professional identity of a physician? And I think there's important considerations here for what our professional identity will be. Are we going to be in a synergistic, symbiotic relationship with AI? Because there's, all this angst about being replaced. And there's multiple scholars in the humanities who've noted that there's certain elements of our identities, like being storytellers, right? We're constantly capturing stories and relaying stories. We're sort of detectives, diagnosticians, and technology has co-opted some of that. And there's been a lot written about how the EHR and the checkboxes and sort of that formulaic, templated medical decision-making is kind of robbing us of some of the things that are core to our identity, or some of the things that drive people to go into medicine. And I think the lesson there is that when we're using AI to automate tasks, we shouldn't be automating the tasks that give us meaning. Let's automate the stuff that's boring, right? Let AI do the medication reconciliation while we talk to the patient about maybe why they're having trouble accessing their medications. Or let AI dig through the discharge summaries to figure out what their hospital course was while we hear the story about what happened today. And so I really think the story is crucial. And I'll just end with saying, we talked about how ambient AI scribes are sort of one of the most commonly used implementations of AI in the ED. They're trained on large language models. They're trained on medical records. And we know that there's stigmatizing language in the medical record that disproportionately affects certain communities. So we have to train ourselves to be critical readers as well, right? Because when that spits out your HPI, it's going to replicate whatever we've written in the chart before. And so I think paying attention to the individual story in the face of big data is going to be our ticket out of a lot of the problems that I think we're anticipating might arise with widespread use. I'll pause there.
I have just a follow-up question. I mean, based on what everyone has said so far, will AI ever be free of bias, right? I mean, if it's trained and modeled off of open access, we're talking about LLMs, open access, non-proprietary data, which itself is biased, and the individuals training the model are biased, is there ever a possibility where anything AI outputs would be biased?
I mean, I'll just say that I don't think that world is feasible. We're never going to be bias free, so
right,
I can't imagine that AI will be.
Exactly. So the developers of the tool are biased.
Right.
And the tool, it's a tool. It's not intrinsically biased, but it's certainly impacted by the inputs from biased users.
Yeah.
So is it just like mitigating it to the point where it's an acceptable level of bias?
I mean, I think I'll let folks who are actually experts in technology speak, but I'll just say, like, when we're trying to mitigate bias amongst individuals, we're not trying to erase bias, right? All the work that's been happening that's probably going to get shut down is around mitigating bias awareness and mitigation strategies. Like, no one thinks that we're going to be able to wipe ourselves of bias, so I can't imagine that there's that kind of a world imaginable for AI, but I'll let you all.
Yeah, I think technically it just is impossible, although the data, any choice, anything you have to choose as a community. I think the goal of this talk in general is to sort of bring to awareness the discussion of that when we talk about, the model is biased, the outputs are biased, whatever, it's all of our values. It's a representation, it's a reflection, as we said, of everything we choose. How we choose to even determine what we think is accurate enough for a model to get deployed, or when we think it's like reached a good enough safety profile, is us setting the limit, just the same way we do in studies. And so to me, that's been the big worry, and the reason to have sessions like this is people think there will just be an answer, and it's very clear that the answer is determined by us, and even asking in the first place what we want and what we expect of this is where it should start, like any other professional question of whether to add any new intervention to our repertoire. But that's all based on us. Any other questions or comments? It's also just to complain about bias in computers.
I do think it's reasonable to desire more people to be aware that the bias is embedded. At some extent, I don't feel like that is not like a targeted goal yet, where providers are approaching AI or even the outputs like, hey, this could potentially have bias, and it's requiring me to still be judicious in how I use it and leverage it. And so that message, I think, can be amplified a little bit more, and it'll help us in terms of how we use the tool, right?
Yeah.
Like if I realize, for example, that, and this is kind of like a more crude example, I have a hammer and a mallet, and I'm like, all right, so this mallet is not going to be as effective as this hammer because of the way it's weighted or because of the material it's made out of. I can elect what to use, when to use it. And I think that that's the approach I would want for clinicians to understand that piece.
Is actually surprised by your comment about the fear of AI in certain communities who may be traditionally marginalized. I kind of noticed just a blind adoption of the technology, and from maybe non-expert users who don't really understand that the answers are not accurate, they're definitely biased, where the source of data is coming from, and then sort of acting on these outputs, and to the point where it's actually contradicting what a trained professional may be less biased is suggesting, and then actually favoring maybe the automated response.
To give you another example.
That actually makes me a little bit more scared, right?
Yeah, no. My father he's in his 70s. He got a message from a chat bot asking him questions about how he felt. My dad immediately called me and said, the government is in my phone. And I said, Dad, no, this is from like the provider. The provider has put these details in there, and then there is a model that's pushing this question to you because of the specific issue that you have. And I'm trying to explain this to him, and he's just like, yeah, I don't like that. And it's not just a fear of technology, it's a fear of the fact that this was running completely automated and that it seemed too personal to him. And so that's what I mean by there is a fear. In some communities, sometimes, you know, it's going to be broadly adopted. There are not going to be particular caveats or considerations based upon age, race, ethnicity, other variables or identifiers. It seems to be like widely approached without taking in that small detail that a 74-year-old black man from Saginaw, Michigan might find this completely invasive.
That's, you know, for any sort of product that you're sort of maybe releasing out to the market, there's going to be different uptake across different groups, right? So maybe for certain generations, through, you know, some factors, demographics, it may not be a well received product. But by the way, the government is definitely in this way.
But it's definitely 1,000%. I was like, that's right. Confirmed, Dan, confirmed.
You're right. It's also like not, I don't think there's probably not a universal opinion about adoption as well, because there are lots of people that use AI chatbots and are like adopted in, you know, for using on your phone. But I think the perspectives are very different if you're like, we're going to run an AI chatbot or run AI on your healthcare data, then people have like very different opinions versus like this is data, like I'm chatting with them, I'm giving this data versus a third party that sort of has your data and is provided, which we all know happens in the background, but I think that process is a little bit different in like how the technology is deployed and like how really does affect how people feel about it.
I think the one other element I would add that I think it's sort of this sort of full circle argument that you could use these technologies to de-bias people because people are already biased, but they are imbued everything is just a reflection of us. So you're like, okay, so I can't really do anything that's fully unbiased. So how do I make use of these technologies, or what do we do? And I think that's where Italo's point in the education and policy element is like, I keep thinking, and the times I give similar talks, of how medical literature was blowing up in the 60s, and there was so much information that they thought doctors wouldn't really like know how to interpret various studies. So journal clubs began then, and like what this is called critical appraisal, because we were like, oh my God, there's all this information. How is the doctor going to know, you know, what to use, what to implement into practice? So that's where the field of like critical appraisal started within medicine for the most part, and then turned into our journal clubs. We learned, hey, oh, is this I remember my journal club was like, what population was this on? What was the outcome of interest? Who did they sample? How many people fell out of the experiment? How do we interpret whether this was a good study or not? And we're pretty good at that. I think a lot of, you know, depends on obviously program to program evaluations. I'm sure different people have different experience with journal clubs, but that's one of the skills we're supposed to come out of medical school and residency with, is how to critically appraise information. And then a lot of the way we're now interacting with models is conversational element. And I've had a family member as well bring me like misinformation, or not even fully misinformation, but they were like, I asked this question from a chatbot, a very smart person, they sent it to me, and I was like, parts of this are not wrong, but where is this in context? Because it was related to who is more corrupt of certain nations and things. I was like, okay, well, let's look at what's the outcome that they look at. How much money was diverted to military from like, okay, what is that as a fraction of their GDP or represented? Whoa, it turns out America is way more corrupt based on that measure than this other country. And how does that relate to your overall question, which is like, what, you know, is the issue that I should support? It was just wild to see. And all that was related to like being given something that's not necessarily wrong in and of itself, but is so out of context and misrepresenting what their actual question was. That makes me think about how good we've gotten at that process, and our sort of responsibility as doctors and part of the community to tell people that's like the approach we're going to have. You have to use this critical appraisal skill for this new technology, and then you can determine how you want to implement things in practice or not. And you don't have to listen. That's why with the license is on us, and why a lot of the AI companies don't want to give final medical recommendations, is someone's still got to be the fall guy. But we also need someone to ultimately determine whether anything is right or wrong for the patient in front of us.
I love what you said, Christian, too, about it, and I think this echoes very well what Colin has been saying, that like humanity perspectives are very important here, because we like all of these things, like, is it biased or not biased? Is it accurate or not accurate? Like, we operate in this paradigm of like one truth, and that's like objectivism, that's post-positivism, that's like a lot of the work that we do in medicine. But we know that like those things are really contingent on the context we're operating in, and like there are variable definitions of like what it means to, what truth means even in a medical context of like describing what's going on in a human's body, which is a really challenging stance to take right now given like the issues with misinformation. But I think like like whether you're deploying to the individual patient or rolling out to a community, you really have to look at like in that context for that person, like what is the impact it's having? Is it accurate for that person? Even if it's biased or not biased by some other measure, or accurate or inaccurate, like is this useful, helpful knowledge? Is it going to do harm? And that's where we need more engagement, because that is going to be a huge amount of work to do.
As a last element on that, there was a great New Yorker article from like last week that was about the humanities in the age of AI by like a history of science professor at Princeton. That is a really good read, and the fact that the humanities are so important in all this, because memories, anecdotal memories, understanding, feeling how it felt to be a patient at a certain time, the sort of discussion around how these will affect our care. It's how we tell the story of our care, how we listen as providers, whether people feel listened to. And I actually think the AI age is a great opportunity to re-engage with some of the soft skills of being a doctor and being a scientist. It's a really great opportunity to take away some of the just calculating you have to do. And there might be a big push to learning more and engaging more in the humanities in general. But I'm totally biased.
Yeah, I think this critical appraisal thing you brought up is really interesting. I wonder if the best way forward to preventing bias in AI is really much more focused education on what different kinds of biases and how to recognize it. I think there's lots of conversations happening about what the future workforce is going to look like, not just for medicine, but for all fields, right? What upskilling and reskilling looks like. And I think a lot of real thought leaders and luminaries in this area think that it's not going to be you doing specific tasks anymore. It's going to be you managing a bunch of AI, right? Agent swarms. And so, whereas before you just have to be conscious of you managing your own bias, now it's compounded across many potential AIs, robots, etc. And how to recognize that happening in other places is probably going to be very difficult without having a very good understanding and critical appraisal of what biases.
Cool. Anything else, guys? Any comments? No? All right. Thanks for being here.
Thank you
Thanks,
very much.